Dr. Lowenstein, are there data to suggest which patients with status epilepticus are most likely to do well, with particular reference to the critically ill patients?
Well, in terms of critically ill, I think most of the data that we have still comes from epidemiological studies, either population-based studies or a look at hospitalized patients, retrospective chart review. And a whole series of papers came out in the 60s and 70s and 80s, which make it quite clear that there are definitely different categories of patients. The patients who do the best are those who have a prior history of epilepsy. And they're presenting as status epilepticus because their epilepsy is refractory, and one of the presentations is ongoing status epilepticus, or there's been some challenge in terms of compliance with medication. And as a group, those patients typically do quite well. Of course, they're not as likely to end up in the intensive care unit, but nonetheless, when you have a patient like that, they tend to do quite well. On the other end of the spectrum, for sure, are patients who are in status epilepticus as a consequence of pancerebral hyperperfusion or anoxia, and those patients almost categorically do far worse. And then there's a whole range of patients in between, some of the more aggressive encephalitides, large strokes, large tumors, severe head trauma tend to be in the worst category. Yeah.
And can you comment on how our typical treatments for status epilepticus compare in critically ill patients?
Right. So, as I'm sure everyone knows, there are sequential approaches to drug treatment in patients. Virtually all of patients who are in status epilepticus, whether its onset has been in the out-of-hospital setting or in the emergency department, and in our video EEG telemetry units and in our ICUs, are first going to be treated with a benzodiazepine, and the most commonly used drug, at least in the United States, is lorazepam. And data have showed that 50 to 60 to 70% of patients will respond to those initial doses of lorazepam. If there's a breakthrough, then a second-line treatment is typically used, and around the world there's quite a bit of variation in what that agent is. In the United States, certainly fosphenytoin seems to predominate, although levetiracetam has become much more commonly used because of its relative ease with regard to drug-drug interaction. But valproate is also commonly used around the world, especially in Europe. And at the moment, it's not entirely clear which one of those three drugs is the most effective in this setting. The other comment I'd make is that these drugs are for sure the typical drug used as a second-line agent. But when you have a patient in the intensive care unit who doesn't respond to the initial doses of lorazepam and doesn't quickly respond to that second-line agent, most ICUs are quite prepared to immediately start a third-line agent, which would be an anesthetic. And the most commonly used drugs there, of course, are propofol, midazolam, or pentobarbital. So that's the approach that's used.
And is there data, or what kind of data do we need to be able to sort out which treatments are most effective?
Yeah, it seems like you've been set up to ask me that question. Because the literature so far makes a fairly compelling case for the fact that both valproate and levetiracetam are effective in the treatment of status epilepticus. So really the question now is which one of these three drugs, fosphenytoin, levetiracetam, and valproate, might be superior. So because of that question, which has been around for actually quite a number of years now, there's been a group of individuals from around the world who have been thinking about how we could go about answering that question. And I'm very pleased to say that just in the past year, a grant funded by NINDS has been approved to really test this question. It's called the Established Status Epilepticus Treatment Trial, or ESET for short. It's going to be based in the United States. It's going to be taking advantage of two very large networks that already exist and have a very strong track record in emergency neurology trials. One of them is called the Neurology Emergency Treatment Trials Network, and the other one is the pediatric network called PCARN. And ESET is designed to test in a randomized fashion, blinded fashion, a comparison of fosphenytoin, valproate, and levetiracetam in patients who have failed lorazepam in the emergency room setting. So this trial is going to require enrolling about 800 patients. It's probably going to take 4 to 5 years to complete, but we think it will be the definitive test of that important question.
And if we look at the patients then who are not responding to one of our second-line agents and now require an anesthetic type agent, we have propofol, midazolam, pentobarbital. Is there data to suggest which of these may be a better choice in the critically ill patient?
No. Again, we have retrospective data, and Simon Shorvone, for example, in London, and his colleagues have done a wonderful job in terms of providing an up-to-date look at the literature on this topic. And it's quite clear that not one of these particular approaches is clearly superior. There are circumstances where you might want to use one versus the other. As one example, I think that pentobarb, which is extremely effective in terms of stopping seizures, but has the very significant adverse side effect of cardiovascular collapse, needs to be used particularly carefully in the elderly. On the other hand, with a young patient who has, say, encephalitis and is otherwise physiologically doing well, I think a drug like pentobarb could be used safely.
Well, thank you very much, Dr. Lowenstein.
Thanks so much.